This is an important topic with the phases of acute kidney injury. The fact that you're even talking about phases automatically puts you in the realm of acute. Keep in mind the time frame. This is not RPGN. This is not chronic renal failure. This is going to be beyond 3 months, 4 months, but this would be obviously less than years. With acute kidney injury, what are these phases that we're referring to? At first, what you're going to take a look at is literally the kidney is shocked. Meaning to say it is undergoing that initial inciting event of your acute kidney injury. So this could include surgery, myocardial shock or cardiogenic shock, or hypovolemic shocks. It's many of those shocks that we've talked about in which all of a sudden the kidney is not functioning. Next, urine osmolality here will be increased in prerenal because aldosterone is removing and ADH is removing the fluid. You expect your urine osmolality to be increased. There's a picture of prerenal. Okay, let's say now the prerenal is causing intrinsic damage to the kidney. You call this what? Renal azotemia. If it's renal azotemia, then you're thinking about the phases that we just walked through. The initial inciting event, that's your initiation phase, and the maintenance phase kind of looks like chronic renal failure. Now, what does this mean? The tube epithelial cells are dead. They're not working properly. These cells at some point maybe then start sloughing into the urine. So you're going to find what kind of casts? Good. You're going to end up having your tubular epithelial granular casts. If it gets really bad, maybe muddy brown type of casts, correct? If the tubular epithelial cells are not working properly, then are you able to properly reabsorb urea? You cannot. If you lose the numerator like crazy, then what then happens to the ratio? Take a look, please, in acute renal failure or acute kidney injury. And if it's an intrinsic problem, you find your BUN creatinine ratio, the bottom row here, being decreased, less than 15. I told you earlier that if you find your azotemia to be decreased, I can guarantee you that you do have kidney problems. Down or decreased BUN creatinine ratio, decreased kidney function. Next, is that the most reliable? No. Here, fraction excretion of sodium. So now the tube epithelial cells are not working properly, and so therefore, can the aldosterone properly work to remove the sodium? No, it cannot. And so therefore, what then happens to the fraction excretion of sodium? You've lost a normal homeostatic mechanism of reabsorption. You're going to have an increase in fraction excretion of sodium. Magic number, greater than 2%. Understand the concept, and then you take a look at the value and memorize. Okay, now here, you'll find an increase in urine sodium, greater than 20. Urine osmolality here. Once again, you cannot properly concentrate the urine because the tube epithelial cells are dead, and therefore it will be decreased urine osmolality. So far, we have 2 phases. Say that you're able to properly take care of the perfusion and such, and you're able to reestablish this. Now what? Well, that's the question that you want to ask. Right before I go on, you'll notice, please, at the bottom of this table that I have not placed post-renal on purpose because with post-renal, the symptoms will be obvious. I gave you BPH, maybe there's a kidney stone, whatnot, and so therefore they'll be back up, and you can expect there to be perhaps hydroureters or hydronephrosis, and you expect your BUN creatinine ratio to be elevated. The only time that you find your BUN creatinine ratio to be decreased would be with, renal or intrinsic azotemia. Let's go on to this last little phase now. Okay, so you reestablished your perfusion, and now, the kidneys are regenerating. Can they? Yes, you can. These are, your tube epithelial cells are quiescent cells. They're quiet, stable cells. When asked to be recruited, they will move from G0 into the G1 phase of your cell cycle, won't they? Yes, they will. So now you've allowed for the cells to regenerate. And as they do so, guess what happens? Oh my goodness gracious. Your kidneys are so happy. It's like a dog walking through the wilderness. And what is it doing? Urinating everywhere. It's marking its territory. This is now welcome to your human marking. So in other words, you're going to have massive recovery phase. If you had maintenance phase, where at oliguria, you weren't producing as much urine, and you had hypervolemia and hyperkalemia, in recovery phase, I'm so happy! I'm urinating everywhere. And you end up having hypovolemia and you have hypokalemia. Are we clear? Once again, I don't think I could be any more dramatic. So you have increased urine volume during the recovery phase. Look at this. 3 liters per day is how much you're losing. That's polyuria. You have hypovolemia, hypokalemia. Compare this to the maintenance phase and restoration of renal function. But very difficult for you to get back to 100%. But pretty darn close, though. Pretty darn close. Now, the outcome depends on the underlying cause. So if there is, let's say you're congestive heart failure and you give a positive inotropic agent, you're able to reestablish your perfusion. Guess what? Hopefully you're able to catch your patient in acute kidney injury and so therefore reestablish and go through initiation phase, maintenance phase, and recovery phase. Treatment, rather supportive, meaning to say dialysis. And then here once again, we've gone through the table here of perirenal and renal azotemia.